Okay, I have Dr. Dunlop who is joining us now. Just give him a couple minutes, just filtering in. Everybody, once again, thank you so much for joining us in tonight's webinar featuring Dr. Ryan Dunlop of Better Life Dentistry and Full Arch Masters, helping us today with CBCT planning for advanced full arch implant cases. And I believe he's with us now. Dr. Ryan Dunlop, how are you?
I'm doing fine. Just finished with my last patient and right in time.
Never a dull moment, huh? Well,
Never
it's
a
it's
dull
right
moment.
after 8. I really don't want to steal too much time from you. I'd really love for you to get into it today. What do you got for
Okay.
us?
Yeah, we're going to talk about a very passionate topic for me. I have done a lot of full arch dentistry in my career, and I started off for many years doing straightforward cases, or so I thought they were straightforward. And pretty quickly into my career, I realized that the majority of patients do not walk in with a perfect amount of bone, a perfect amount of, non-infected sites, and a perfect medical history. And so I realized that some of these advanced procedures that I'll talk about tonight are very, very much so needed in the full arch world. And if you don't have an understanding of what these are, you can fall into the abyss of despair very quickly. So it's important that all dentists who are working in full arch understand the difference between routine, straightforward, all on four or all on X cases, and then more complicated, advanced all on X cases. So if I have 30 seconds, I'd like to get a cup of water so I don't end up coughing. So let me grab water for just 2 seconds.
Feel free, doctor. It's all right. So, once again, let me just reiterate, if anybody has any questions, please feel free to enter them in the chat. We always get to them when we have time here. If any questions may evade you later on, please feel free to send us any questions. Reach out to us, marketing@rayamerica.com. You could also connect with me, a demonstration of sorts. We'll be able to take you to some of the software, some images, and answer some of your questions. RayScanAcademy.com will be able to do that for you, or just reach out to the marketing. We'll be able to get you a rep out to your area. So thank you once again for joining us tonight, everybody. Really appreciate it.
All right. Now I won't have a coughing fit in the middle of my presentation.
Wonderful.
Okay, my turn.
Yes, sir.
All right, I'm going to share my screen and we'll get going here. If you guys have questions along the way, please do not hesitate. You can put them in the chat. We will get to all of them at the end of the presentation. You guys can see my screen okay?
Yes, doctor.
Okay, so we're going to talk about CBCT planning for advanced full arch implant cases. I am Dr. Ryan Dunlop. As mentioned, I am the founder of Full Arch Masters. Also, I run a busy implant and sedation clinic here in Fresno, California, named Better Life Center for Implant and General Dentistry. Teach a lot of courses around the country, both live surgical courses, laboratory courses, a whole array of education opportunities for people who are interested in furthering their knowledge in full arch dentistry. Um, just a little background about me. I graduated from Harvard Dental School in 2006. After that, I did 2 years of general practice residency at the Mount Sinai Bronx VA Hospital in New York City. That's where I really honed my craft and got used to surgery, placing dental implants, working on sedated patients. After my stint there, I moved back to California with my wife, and I worked in a practice from 2008 to 2015, where I was an associate dentist, but doing sedation, quadrant dentistry, full arch dentistry, removable and fixed implant dentistry. So got a lot of experience there. Opened up my own practice in 2015. Started my own lab in 2017 and then started Full Arch Masters in 2018. So a lot of experience in implant dentistry, a lot of different implant systems, different sedation systems. And so I really reached a point in my career where I'm very stable and very satisfied with the level of care that I give, but I'm always trying to learn more. Um, so today we're going to talk about kind of I think I would call this like the apex predator in the full arch world. These are the great white sharks. These are the tiger sharks and the killer whales that are lurking around in the full arch world. And if you're not prepared to at least identify these cases and understand the complexities of them, then there's a very good chance you will be devoured and eaten for dinner by one of these apex predators. So I get a lot of nervous phone calls and a lot of nervous text messages saying, "Hey, Dr. Dunlop, I'm in the middle of surgery. I can't get anything to torque. The patient's expecting teeth. I don't have any bone. What do I do?" My answer is always, well, you start over and you come to Full Arch Masters and you get the right training and you learn how to do these advanced surgical cases before you ever lay hands on a patient. Because they can fool you. They can really, really, really make you feel insecure and scared. And if you don't know what you're doing, you can make some major mistakes. Uh, so at our courses, we teach kind of the difference between traditional all on X cases, which are standard all on four, all on six cases, versus our advanced all on X cases. And what's the difference? Well, I kind of classify them into two categories. The traditional all-on-X cases use, 4 to 6 implants with really good support from molar to molar. So first molar to first molar. You can tilt the implants or you can leave them vertical. It just depends on the bone volume and the anatomy. You can tilt 2 of them. You can tilt all 4 of them as kind of an M configuration. Uh, but it's more or less the standard Palomalu all-on-4 type restoration. See some questions coming in already. Um, the advanced all on X cases, hey guys, if you want to look at those chats, if there's anything pressing or if there's anything specific to what I'm talking about, just interrupt me, okay?
Yes, sir.
Um, the advanced all on X cases are where you start introducing something that is outside of the norm of the kind of standard all on X procedure where we're using 13s and 16 millimeter implants with good support from molar to molar, 4 to 6 implants per arch. Once you start getting away from that kind of standard, then you start talking about more advanced all-in-X cases. So advanced all-in-X cases have pterygoid implants, which we'll talk about. They have palatal approach implants, which we'll talk about. Trans-sinus implants, which are very interesting. And we'll touch a little bit on zygomatic implants. Zygomatic implants are my least favorite implant to place. They're the most complicated. They're fraught with the most potential complications. So you'll see as I go through my presentation, I really try to avoid zygomatic implants for every case. It should be the implant of last resort because it's such an invasive surgery. There's a lot of potential complications associated with them, both intraoperatively and postoperatively. And unless you really, really, really have a lot of experience with managing sinus complications and dermocutaneous complications and long-term nerve issues, you shouldn't really be doing or planning zygomatic implants. But pterygoid implants, palatal approach, even some trans-sinus approach, I think these are very reasonable things for the full arch dentist to understand, but also to even do in their practice. So here's kind of an example of a variety of different types of cases that I've done. Starting on the top left, we see a lot of kind of straight implants. Um, we see upper 6 implants and lower 5. But the implants are relatively straight in the bone. The teeth are relatively straight over the implants. And at least from an X-ray perspective, this looks like a pretty straightforward case where you didn't have to do anything heroic. On the second slide on the top, you see really similar, especially the mandible, except now we've got some tilted implants to avoid some of this anatomy that gets in our way. And so on the upper jaw, you can see the posterior implants are tilted forward a little bit, and that's to avoid the anterior wall of the sinus. And then on the lower, you start to see some tilted implants on the lower, and that's to avoid the mental nerve and the mental foramen as they come out of the jaw. Uh, On the top right, you see a little bit more tilting on these implants. And what that means is there's just a little bit more anatomy that we had to avoid. And so we're still tilting our implants on the upper to avoid the sinus, sometimes to avoid the nasal floor. And we're tilting our implants on the mandible now to avoid the mental nerve. and the inferior alveolar nerve. So now we've got a little bit more of a distal extension. We've got that supported with a metal bar. And so that's kind of the next level up. On the middle row to the left, we see a case that has a lot of tilted implants now. So we've got a combination of straight implants, we've got tilted implants, we've got pterygoid implants now that are in the back of the maxilla. We've got implants going through impacted teeth. We've got implants in the vomer. Like there's just, it's like a cornucopia of dental implantology here, but no zygomatics. So we did everything that we could using the patient's anatomy and tilted implants in order to avoid the patient having to use their zygomas for anchorage. On the middle slide, we see a case where the pterygoid bone was used, the pterygoid plates, to give additional support for the distal extension of the upper jaw. On the lower, we see six dental implants with two tilted ones in the middle, and the rest of them look pretty straight. On the center right side, we have a case of zygomatic implants and tilted implants and straight implants and short implants and pterygoid implants. So there's a lot of options on a case like this for being able to get anchorage for your dental implants so that you can give patients teeth the same day. On the bottom left, we see another combination of zygomatics and tilted implants. We have some transsinus implants here. Um, we have some zygomatics and pterygoids, and then on the lower jaw, we have that same combination of straight and tilted implants. And then the last two cases are kind of the most complex that I would see. These are zygomatic implants, pterygoid implants, transnasal implants, transsinus, vomer, tilted implants. I mean, we've got everything but the kitchen sink on these two. And then the last one on the bottom right is kind of our most complicated case. These are patients who have little to no bone left anywhere in their maxilla. So this is a pterygoid case. We've got quad zygomas. So we've got four zygomatic implants from the cheekbones coming down into the mouth. So this is a person, at least on the upper jaw, that has little to no alveolar bone left whatsoever. They've probably been in a denture for 40 years and they're looking for some sort of solution so that at least we can provide some sort of solution for them. So I'll go through a couple of basic surgical slides so everybody understands what full arch implant dentistry is like, at least at Full Arch Masters. So the initial incision is a crestal incision. You can see on the palate here, I've placed two metal screws on the palate. These form the base of our digital workflow. This isn't a digital workflow lecture, but just understand that we place those before surgery, right before surgery, so that we have something as kind of like a geometric home base. So I make a crestal incision across the ridge, in this case from molar to molar and around the existing teeth. I like to raise a buccal flap afterwards so that I can get really good visualization of the tooth roots. Sometimes we have tough teeth that we need to take out and we don't want to blow out all of our buccal bones. So I like to raise my buccal flap first so that I can see where I'm going. Then I proceed to take the teeth out. Excuse me. Taking the teeth out is pretty simple in a full arch case because there's usually not too many of them left. And usually the ones that are left are either infected or have periodontal disease. So they're usually pretty simple to take out. In this case, I took these roots out in probably about maybe 8 to 10 minutes. But having that buccal flap already open and pushed up really allows me to get the teeth out quicker. Once I have the teeth out, then I raise a palatal flap. And by doing this, I'm able to really isolate the ridge and get the case ready for implant placement very quickly. Once I have the palatal tissue sutured together, then it's easier for me to reflect the buccal, and I perform what's called an alveoloplasty. An alveoloplasty is bone reduction. It's very important that we reduce enough bone on these cases. Usually working with the Full Arch Masters lab, we give detailed instructions on how much bone they recommend removing for each case. So we make measurements, and then there's a variety of techniques that we can use to remove bone. I like to use ceramic burrs because they don't overheat and they cut a very, very flat table like this. Some people will use saws. Some people will use like rongeur, bone file. There's a lot of different ways to remove bone. At our courses, we teach kind of a handpiece driven acrylic burr, ceramic acrylic burr to really mow down that bone in a quick, efficient, clean way, but also to have it be very, very flat for our implants. Once the bone is reduced to a sufficient level, then based on our plan, which we'll go through some of the CBCT planning in a bit, but based on the plan, we freehand our surgeries and we place the dental implants into the ridge in the configuration that we planned ahead of surgery. So in this case, I placed 4 dental implants, and as soon as the implants are in, then we put what's called our multi-unit abutments on top, and those are the base for our future teeth that are going to be delivered at the same time. Once I have those abutments in place, those are torqued down according to the manufacturer's specifications. I use a lot of photogrammetry in my clinic. If you don't know what that is, it's a separate scanning system solely for implant positions. So it only does one thing, and it does it very, very well. It gives you your exact implant positions down to 5 or 10 microns. So you get a linked data set of all 4 implant positions in space that you can use in exocad to build your immediate load bridge. After I take that photogrammetry measurement, I put special healing caps on, which are tissue scan bodies. They're basically scan bodies that are very, very short. We're not using them for implant position. We're only using them as a reference to link them to our exocad case. So we put the scan bodies on, we suture everything closed like this, and then we take an intraoral scan, like with a Medit or Trios or Prime Scan or one of those intraoral scanners, and we scan this in the mouth. And this allows us to in the lab to link our design to the surgery and create a printable prosthetic that we can put in each day, same day. On the lower jaw, I tend to do half of the jaw first and then the other half. The reason for that is I don't have a pallet like on this. If I go back a slide, on this I have that home base of those 2 screws on the pallet. Those act as our scanning base so that we can link our pre-op scans to our post-op scans. Even though everything in the mouth changed, the position of these 2 screws did not. So in the laboratory, when you look at exocad, you can layer your scans on top of each other based on common geometry. And so on the mandible, we don't have a common geometry because the tongue is in the way, and there's no way for us to put a rigid marker in the middle of the mouth that doesn't change. So we have to use something else, and we can install markers on other parts of the mouth. But in a case like this, where there's no room for any markers like that, then we just use the teeth. And the way we use the teeth is by choosing which side we want to leave, and then we do the other side first. So in this case, I left the patient's right side, even though it's mirrored, so it looks like left here, but it's the patient's right side, and I took out the periodontally involved teeth, and I smoothed the bone down on one side, and I placed the 3 dental implants that you can see on the right side. So I placed site 26, 28, and 30, but I left the one side, the entire left side untouched, and I also left the second molar untouched. So that when we scan this or take an impression of this in surgery, we have the pre-op to link to because it has all the same existing teeth. But then we also have the implants to link to for the second half of the surgery. So we kind of create a bridge between pre-op and post-op by leaving half of the teeth alone and doing one half of the surgery at a time. After you get that kind of mid-operatory scan, then you can proceed to do the rest of the surgery. In this case, I did the other side. I decided to leave those second molars as an additional reference at the end, so you can see them in the back, and then I take those off take those back molars out at the very end. So you can see again, registering the implant positions during surgery using photogrammetry. This is much more accurate and more reliable than any other method for registering where your implants are in surgery. After the photogrammetry measurement, just like we did for the maxilla, we're going to come back and now suture the lower jaw and take a tissue scan record with those same caps. So just kind of as a summary, you install your markers if you're going to use those, which were those screws on the pallet, then raise your buccal flap, either extract all the teeth if you're able to use markers or half of the teeth if you're not able to use markers. Then you raise the rest of your flap and get access to the ridge so that you can reduce the bone. Then you install your implants and your multi-units, and you do a mid-op scan if you're doing the mandible. You do your photogrammetry scans to get your implant positions, and then you close the case up with suturing, and you scan again at the very end. So just that's just kind of a brief overview so you guys understand kind of the basic surgical principles for a standard case. We're going to talk a little bit more about the advanced surgical cases now. Um, we're going to cover some anatomy and some surgical techniques, some of the complications associated with this, and then some of the unique prosthetic considerations that these cases provide. This is a great quote from one of my alumni and friends, Justin Scott from Atlanta. He said, the goal is to be able to do 99.9% of the cases. And I think that's true. I think that there's some patients that just don't qualify for this. I think that either they're medically compromised or they just have absolutely no bone whatsoever. Yeah, you can come in. So between the advanced techniques that I'm going to talk about now, I think it's very, very possible for the full arch dentist to be able to do up to 99.9% of the cases. So these are the main advanced surgical techniques that I use in my clinic every single day. I'm not going to talk too much about zygomatic implants. I think that's a completely separate subject that we can spend an hour on at a different time. And the reason for that is between transsinus implants, pterygoid implants, and palatal approach implants, I have virtually eliminated the need for zygomatic implants in my practice. I still have maybe 5 or 6 cases a year that need zygomatics, but it's getting less and less every year. And the reason for that is I'm getting better at doing transsinus, pterygoid, and palatal approach implants. And it's the risks associated with these other procedures are far less than the risks associated with zygomatic cases. And so I think that zygomatic implants slowly will start to fade as a viable treatment option. There's still going to be some patients that need them. But again, as I'm running a full arch practice that does full arch cases every day, even I find myself doing them less and less. So let's talk about transsinus implants. These are very valuable implants for increasing AP spread in severely resorbed cases, but they're very, very tricky to do. The key is really in the diagnosis, the treatment plan, and the surgical technique of these. First and foremost being the diagnosis. There's very, very strict diagnostic criteria that I use to choose someone to receive a transsinus implant. And we'll talk about that. And then the treatment plan and the surgical technique is very, very, very tricky and very technique sensitive. It's very easy to go for things to go wrong. So let's talk a little bit more about transsinus implantology. So transsinus implants are really just a regular implant. They tend to be a little bit longer because of where you're starting and where you're going to. So they can be 18, 20, or 22 millimeters in length. Sometimes they're shorter than that, but this is kind of the average. But the basic idea is that it goes from the alveolar ridge, where the teeth used to be, through the emptiness of the sinus, and then engages on the opposite side of the sinus into the paranasal bone called the piriform process or the piriform rim. That is an area of bone on the sides of the nose that is almost always very dense bone. So we can go from the ridge through the air of the sinus and then engage the bone on the opposite end of the sinus on the side of the nose. So if you visualize that, I have some other pictures that I'll show you, but you want to have some bone at the crest, which is ideally 4 to 6 millimeters, to anchor the coronal aspect of the implant. Then you can have up to 10 to 12 millimeters of empty space where you're just going through air. And then at the opposite end of the implant where the apex is, you want to have another 4 to 5 millimeters of bone for the implant to anchor into. So the rest of the sinus is either in air or it's hugging the sinus wall. But if you think about it, you still have 8 to 10 millimeters of implant in bone, just not through the center of the implant. So the benefits of a transsinus implant is that it greatly can enhance AP spread in a resorbed case. So if you would have to, let's say, keep your implants between the canines or the first bicuspid, by doing transsinus, you can push the head of that implant back further to the first bicuspid, second bicuspid, or sometimes even the molar. Another benefit of these is if you think about it, you're going potentially through 4 cortical plates. The ridge, the crest of the ridge, which if it's resorbed and you're not reducing bone, will have a cortical plate. Then the floor of the sinus, which is also a cortical plate. Then it's going to be an air. And then on the opposite end of the sinus, you've got the roof of the sinus or the lateral wall, which is another cortical plate. And then through the piriform process of bone, you've got the base of the or the lateral aspect of the nose. So you have potentially four cortical plates for this implant to engage and compress bone. So they're very, if they're done well, they're very likely to get very high insertion torque, and that allows you to do great things with them. The risk is that if you don't achieve high torque, then there's something probably very wrong with the placement of your implant. So we do always want to load these cases because the literature shows that when they're not loaded, there's a very high risk of implant failure and sinus complication. So if it's done well, then it has very high insertion torque and things go extremely well. If if it's not done correctly and you miss the apex of the second insertion point, or you're not in the lateral bone of the nose, it's very easy to get off track with these and lose your position. And then there's a very high likelihood of complications and implant failure. So again, it's technique sensitive, and you need to know how to do these and have the right mentorship before you do them. So what is the role of the sinus in these cases? Well, if you look in the literature, there's kind of three types of transsinus implants. One is kind of hugging the sinus wall, which is kind of a fully bony transsinus. The second type is where the distal aspect of the implant kind of glances and invades the sinus membrane. And then the last type of transsinus is one where the entire body of the implant goes through the empty sinus cavity and engages bone on the other side. So my kind of rule of thumb is that if I'm just hugging the sinus wall, like in the first two cases, I do not enter the sinus with the lateral window and push that membrane out of the way. Um, if the sinus is at all diseased, if I see, signs of chronic inflammation in the sinus floor, then I will go in and I will push the sinus floor out of the way before I do my transsinus implant. And by doing that, you're essentially doing a sinus lift. There's just really no need to graft it. You can just lift the implant, I'm sorry, you can lift the sinus membrane out of the way, and you can put the implant underneath it and then allow the sinus membrane to kind of fall down on top of the implant. Because what it's doing is the implant body is tenting up the membrane, and the blood clot that forms underneath it will turn into new bone. So there's really no reason to graft it. I don't graft these, especially because I'm only doing the sinus elevation in a sick or diseased sinus. And the last thing I want to do is introduce foreign bodies or some bone graft material into a diseased sinus. So the rule of thumb is if you're glancing the sinus membrane or barely going through it, there's no need to raise the flap and raise the membrane. If you do go through the sinus in a significant way, and the sinus shows signs of pathology already, then you want to get in there with a lateral window and push that membrane out of the way so that you can allow the membrane to fall down onto the implant instead of going through it. So in terms of surgical technique, like I said, you can decide ahead of time if you want to raise a window, like a lateral window into the sinus, something you would do for a sinus lift or something like that. If you need to visualize the implant or you need to raise the sinus floor membrane. But you want to make sure that your flap goes up high enough so that you can raise that window. Also, you need to make sure that your buccal flap is high enough to the side of the nose so that you can see the insertion point for the apex of the implant. Um, like I said, the diagnosis is key. I only do transsinus implants when there's enough bone under the sinus on the ridge. So I look for 3 to 4 millimeters at least of leftover alveolar bone. What I do is I start with a 2 millimeter drill, and I go through that 3 to 4 millimeters at the crest, and then I feel a loss of resistance, and I know that I'm in the sinus. Then I extend the drill further forward, which now you can understand why these are usually longer implants. But I'll go until I reach a hard stop on the opposite side of the sinus. And from there, I will extend my osteotomy through the opposite wall of the sinus and up to the base of the lateral aspect of the nose. So I finish the osteotomy when I when I puncture the kind of like the fourth cortex. So the bottom of the red line here is your first cortex. The second red line is the floor of the sinus. That's your second cortex. The opposite end of the drill of the sinus is your third cortex, and the base of the nose is the fourth cortex. So once you kind of perforate through the base of the nose, then you know you've got the position where you want it. So once I have that position, and sometimes I will confirm that with like an X-ray during surgery just to make sure I'm exactly where I want to be. Then I go back and I take my subsequently larger osteotomies and I make the osteotomy wider and wider, always under preparing these, right? So I want to have high insertion torque, so I don't want to over prepare these osteotomies. Like I mentioned, these are usually longer implants, as you can see here. I think this is actually a video. So this is a video of one of our students placing a transsinus implant with very little insertion torque. It's like floating in until it reaches its final destination, and then it just stops like a hard rock. And the reason for that is he got it to engage into the second osteotomy that's on the opposite side of the sinus. So now he's going back because the motorized torque reached its max. Now I'm telling him to go back with his torque wrench and take this down the rest of the way by hand. And you can see that going from very low torque initially, where the implant was just feeding in very quickly, to very high torque very quickly is exactly what we want from a transsinus implant. So he's taking this down the rest of the way, and now you can see his torque is basically at the max. So it went from very, very low torque to very, very high torque very quickly. And that's what we want. We want a high insertion torque, and we want to make sure that we can load these cases the same day. So this is what a transsinus implant looks like after we are done. You can see that I go through the alveolar ridge. There's about maybe 4 to 5 millimeters of alveolar ridge, and you can see how,
Doctor, can I
yeah,
pause you for just a second because I think it's really relevant, this question that's asked. What's the max torque that you are applying? And could you define high torque, please?
right. So people are always shocked when they come to my classes and they just start doing surgery with us because I and all of the mentors that I have in my courses, we put implants in at very high torque. And when I say very high torque, I mean like more than 100 Newton centimeters. And when people learn about implant dentistry, we learn about 35 Newton centimeters for torque, maybe 40, maybe 50. Otherwise, you'll get something called compression necrosis, right? So that's kind of a term that floats around where if you over compress the bone with a dental implant, somehow the bone will die back. And that just doesn't seem to be the case. Cases where I've seen actual necrosis around an implant is actually not from the compression, but the overheating of the bone. So when you have a surgical guide that blocks your irrigation to getting to the osteotomy, or when you're spinning your drill inside an osteotomy and there's no irrigation getting deep under there, that's when you start to see problems. You can routinely put implants in. In fact, my case today, I was putting implants in at 90 plus, all of them. Now, the only exception to that rule that I will say is on mandibular bone, where it's really, really dense cortical bone. If you put implants in at very, very high torque, a couple of things can happen. You can either break the implant, you can break your drivers, or you can see bone loss in that very, very dense cortical bone. So when I have very avascular type 1 dense bone that doesn't really bleed, then I will go back and I will prep more and try and get the implant to seat somewhere between 30 to 50 Newton centimeters. But every other case, from all maxillary implants to pterygoids and zygomatics, we are routinely putting implants in at 90 Newton centimeters plus. Good question.
Thank you, doctor.
Okay, so yeah, so this is how transsinus implants end up looking. These are both cases that I've done that I did a very long time ago, and I've seen them for years and years and years. You will see some chronic sinus inflammation around the threads of the implant. You will see some sinus membrane thickening, just like if you had a zygomatic implant. Transsinus implants are basically zygomatic implants just going a different direction. Instead of going up and laterally to the zygoma, they're going up and medially towards the nose. So you have the same kind of similar risk factors of chronic sinusitis, discharge, th sinus membrane thickening. So patients need to understand the risks and benefits of these different types of procedures. Okay, so the next type of advanced surgical technique we're going to talk about is pterygoid implants. These are actually very old implants. They've been around since the 1970s and 80s. They were some of the first dental implants that were actually used. And then they went away because they're high risk and we weren't doing a lot of the same immediate load procedures that we are now. So these implants have made a tremendous comeback in the last 10 years because of the desire for immediate loading. And immediate loading and distal extension support has become really important to us as full arch doctors. So even though they're old, this is old technology and this is an old technique, the ability to get an enhanced AP spread on maxillary cases and the ability to load these cases because of their high initial insertion torque has really made these pterygoid implants a popular methodology. So to review a little bit of basic anatomy, we're trying to get the apex of an implant to engage the very dense cortical bone of the medial pterygoid plate, or the bone in between the medial and lateral pterygoid plate. So pterygoid implants should start ideally around the second molar, and they should tilt back about 30 to 40 degrees, and they should tilt up and towards the midline about 10 to 15 degrees. So kind of a rule of thumb is 30 degrees tilted back towards the back of the head. And then that's from vertical, like from a vertical plane. And then tilted in about 10 to 15 degrees from vertical towards the midline. So to look at that in a kind of different way, we're starting at the tuberosity of the maxilla and we're going through kind of the pyramidal process into the pterygoid process and engaging the bone that exists at the medial pterygoid plate or between the medial and lateral pterygoid plates. This bone up far from the tuberosity, usually 16 or 18 or 20 millimeters away from the tuberosity, is very dense cortical bone, and it's very good for anchoring kind of sharply pointed or sharply tapered implants. So you can get a really high insertion torque here, even though the maxillary tuberosity bone is often some of the worst bone for osseointegration. We're not relying on the tuberosity bone for the integration. We're relying on the pterygoid plate, the pterygoid plexus bone for our integration. So the key to doing successful pterygoid implants is the diagnosis of this. For me, I want to have a thick, robust tuberosity for these implants because if you can see from this X-ray, the pterygoid plates is that dense vertical bone above the maxillary tuberosity, and you can see that with a big, robust tuberosity, there's kind of a funnel. There's kind of a medial and lateral funnel that leads up to the pterygoid plate. And without that tuberosity, it can be very, very dangerous and very
Right.
complication heavy to get a pterygoid to sit. Was there a question? No.
No, doctor, sorry.
So my rule of thumb, especially for beginners, is that if there's no tuberosity, there should not be a pterygoid implant. Clear as day. You need the tuberosity to be able to stay away from some of the crucial anatomy of the area. And the only basic anatomical structures that are in the area that we need to be aware of are the greater palatine artery. Okay, so the greater palatine artery, if you do a lot of denture work or you flap for wisdom teeth, you know that the greater palatine foramen is palatal to like the second to third molar area. And it's usually a very safe exploration. If you need to flat back there, you can just push gently up until you get to the greater palatine foramen and nothing ever really happens. But as soon as you nick that greater palatine foramen, you just get really fast bleeding. It's not that hard to stop if you have a cautery or you put pressure on it, but it's a little scary when it happens. So as for a pterygoid implant, we are directly invading the space of the descending the greater palatine artery. So we have to be very, very careful and respectful of that anatomy. And the only way to really do that is to follow the tuberosity. And when you follow the tuberosity, as I've done here, you can really have a predictable result where your implant engages very dense cortical bone and gives you tremendous support for your maxillary arch. So the problem with pterygoid implants is that no matter what you do, it's pretty much a blind procedure. There's no way for you to raise a flap to see all the way up to where the apex of your implant is going because there's too much anatomy there. We can't get up there. So you have to have a very an anatomically guided and haptic approach. The tuberosity will not give you any stability, even if you try to use a surgical guide or try to use some sort of guide to help you get to the pterygoid bone. The tuberosity is not going to be reliable for you. Most of the time, it's just soft and full of fat and not rigid enough to really use it for any type of guidance. Um, so, as I mentioned, the major anatomical structure is the greater palatine artery. It lurks kind of medially to the site. So, if you remember, I said that pterygoid implants lean in about 5 to 10 degrees from midline to the middle. And if you go too angled, if you angle your implant too much towards the midline, you can hit the greater palatine artery, and all it does is cause a lot of bleeding, and then you have to manage that surgically. The maxillary artery is in the neighborhood, although it's extremely high. It's like 25 to 30 millimeters from the tuberosity. So unless you are placing a 25 to 30 millimeter implant, there's almost no risk that you could hit that artery unless you were to, say, lose your implant and have it shoot up into the infratemporal fossa, and then you might clip the maxillary artery, which would obviously would be a tremendous medical emergency. So surgically, pterygoids look something like this. You want to have a mid-crestal incision that kind of curves similar to a like a maxillary wisdom tooth incision. So mid-crestal incision that kind of curves back and towards the hamular notch. The hamular notch is behind the tuberosity, and it's kind of a bony projection that you can usually feel with your finger. And so it's a good destination point for you to extend your flap back. I like to do my mid-crestal incision and then push the buccal tissue out first because that's typically a safe zone. I will use like a periosteal elevator or some sort of reflector, and I will get the buccal aspect of the flap raised first, and then I want to walk around the distal aspect of the tuberosity and expose the distal side of the tuberosity. And there's a kind of a notch between the distal aspect of the tuberosity and the hamulus. My first tool that I like to use, my instrument that I like to go to, is a 2.0 pointed osteotome. I like to press this through that spongy, soft maxillary tuberosity bone and let it kind of guide me up to the medial pterygoid plate. When I do that, I kind of reach a hard stop. I reach like a wall, and then I use a mallet to tap very gently on that osteotome, and I listen to the sound, and I kind of guide the osteotome as it advances superiorly, following the densest sound. And if you've ever used an osteotome, you know that as the osteotome is advancing, it kind of gives a dull thud. And then when it hits something really, really dense, you get kind of a high-pitched ping. And that high-pitched ping is what you're looking for. That's when you've really hit something super hard and dense. After I reach that hard point, then I want to go back into the osteotomy with a drill and actually puncture through that plate a little bit. And the reason for that is I want the apex of my implant to engage and actually go through and perforate the plate, because as I tighten the implant down, I'll increase the torque. So I start with the 2.0 osteotome, then I go with some sort of pointed 2 millimeter drill, and I drill up with my handpiece, always feeling like I'm on a hard surface. I don't just drill blindly. I drill like 1 to 2 millimeters at a time until I feel a loss of resistance. And when I feel that loss of resistance, which is usually around 16 to 20 millimeters, I just stop. I don't have to advance any further. After I get that kind of release point into the pterygoid bone, I go back in with a larger osteotome. That's usually like a three millimeter, and I use the mallet and I tap that again. What this does is it kind of widens the tuberosity bone for me and condenses the bone around the pterygoid plate. If I feel like it's soft bone and it's kind of advancing just with this mallet, I will go ahead and I will put the implant in right then. If it's dense bone and I'm kind of stopping halfway, I will go back with my larger drill, and I will take like the 3.5 drill almost to depth, and then I'll go ahead and put my implant in. But these are designed to be underprepared because, again, the tuberosity bone doesn't offer us any support. And then as you advance the implant, you want it to have a glide path that takes you through the pterygoid plates so that as you advance the implant more and more, it's increasing in torque. So it's very easy to get off track with pterygoid implants because, again, you are placing it blind. Here's a case that I did where I actually was too vertical and I kind of ended up halfway into the sinus. I had torque on it, um, so I left it, but I went one site forward and I placed a tuberosity implant just as a backup, and I ended up using that one. Um, so it's very easy to get off track on these. You definitely have to have a skilled mentor helping you when you're learning how to do these. It's very disorienting because you don't have very many landmarks. The teeth are usually gone, and it's a very awkward kind of ergonomic position. I have found that right-handed operators tend to place the right pterygoid better because they can see it, but when they go to do the left pterygoid, they tend to have to lean over the patient and they lose all context and perspective and usually end up putting implants in at funny angles. All right, the next approach that I'm going to talk about is one of my favorites. It's the palatal approach. I have avoided zygomatic implants and sinus lifts on too many cases to count because of this little technique. This is for severely resorbed ridges, where there's not enough width to put the implant all the way in bone. So we place the implant palatal on the inside of the thin ridge, and then we want both hard tissue integration and soft tissue integration. So you get hard tissue integration on the buccal and the apex of the implant, and then you allow the soft tissue of the palate to rest against the exposed threads of the implant. So this is for severely resorbed ridges. You want to have at least 2 millimeters of bone on the buccal aspect of the implant, but it avoids the need for very extensive grafting cases and zygomatic surgeries. And these, again, usually get very, very high insertion torque because it's basically all in cortical bone. I don't ever not load these. These are another instance where sending the patient home with a denture is going to put the implant at high risk for failure because the denture is going to be pressing and moving the tissue on the palatal side of your implant, and that can trigger inflammation and bone loss. So you can get pretty extensive with these. This is a case that I did with a colleague, Dr. D'Souza, at one of our courses, and you can see, this is a very, very extreme case of a resorption. This is a lady who had been smoking for 40 to 50 years and had been in a denture for almost as long, and we were able to put an implant completely palatal to the ridge on all four implants, and you can see more than half of the implant on the palatal is exposed. And this does fine. These implants last, they do great. Patients can get rid of their dentures and they can start living life that, the way that they want. And you have to understand these people are pretty resorbed, so they're not even doing well with dentures. They're not eating, they're not keeping good nutrition, their self-esteem is in the gutter. And so you can really give somebody a beautiful new lease on life by doing this. The secret to this is our little friend, the hemidesmosome. If you think back to dental school, the desmosomes are interstitial organelles. They link cells together, but the hemidesmosomes link cells to hard surfaces. So when you have tendons attaching to bone, or you have teeth attaching to bone, or you have gingiva attaching to teeth, that's where you get hemidesmosomes. And they're kind of like Velcro. They kind of act like Velcro, where gum tissue will adhere to the roughened surface of the dentin and attach to it. Um, so when we have an exposed thread of our implant and it's kind of a rough surface, these hemidesmosomes will attach to the surface of the implant and kind of seal off the peri-implant tissue like Velcro. And so you get really healthy looking palatal tissue even years after placing these palatal approach implants. Because it's really just a normal part of the junctional epithelium that is being tricked into attaching to the roughened surface of an implant rather than the dentin of a tooth. So the technique for these is kind of fun because you get to do kind of the palatal approach swing. What I do is I start my osteotomy almost at a 90-degree angle from the ridge. And then as soon as I have a kind of a small purchase point, I swing the drill 90 degrees and proceed at a different angulation. And so that swing kind of twists the drill in the bone and starts your osteotomy completely palatal to the ridge. This works very well for both posterior and anterior positions. And it's a fun technique, but it's a dangerous technique because I've broken a few drills doing this. That lateral 90-degree swing, if you're pushing too hard and you're inside dense bone, you can snap a drill off inside the bone. So you just have to be careful with that. So this is kind of what the palatal approach implants look like on CBCT. You can see I've pre-planned ahead for the length and the diameter of the implant. And you can see, I have two choices. I can either reduce this ridge all the way up to almost that blue line and put a very, very short implant in, or I can leave the ridge almost at full height and just move the implant bodily towards the palate. And this does much, much better than placing little short implants with huge cantilevers on them. So you can see here for this patient, I have a posterior one on site 2.5. I have an anterior one on site 1.5, but they have the same look. They're completely palatally placed. This was one of my assistant's moms that we did this on. So you can see how long those implants are. This was that extreme case that I told you about, where more than half of the palatal aspect of the implant was exposed. So you can see, and she's had this for, gosh, maybe 6 or 7 years now, and she's doing fine. But you just appreciate how much bone to implant contact we got on an otherwise hopeless case that would probably need quad zygomas and pterygoids and stuff. And we were able to get it done in a much less invasive manner. So let's talk about a few case examples. This is a patient that was referred to me. Some other dentists had done this lower work and really struggled with it, so referred the rest of the work to me. And so I treatment planned her upper. I kind of mapped out the full extent of the maxilla, and I saw that her sinus on both sides, but more so on the left side, really extended far forward almost to the canine space. So I saw this as a good opportunity to place some pterygoid and transsinus implants. She needed a tremendous amount of bone reduction. You can see here. She has a very gummy smile. She hated that about her smile. So I wanted to reduce a lot of bone to get her smile line and incisal edge position up. So she was ready to do this. This was kind of the general schematic on how I explained it to the patient. I said that I'm going to place transsinus implants that go from your bone through the sinus and into your bone on the sides of your nose. I'm going to place regular traditional straight implants for full arch on the anterior of your jaw. And then I'm going to supplement and add some support to the back of your mouth by doing these pterygoid tilted implants. Then I went to the CBCT and planned these out in more detail. This is where understanding your anatomy and understanding how your CBCT can give you detailed views of your anatomy really helps you. So I plan most of my pterygoids off of panoramic X-ray, but I do go back and I measure the length from the tuberosity where my insertion point is going to be up to the pterygoid plates. And so in this case, you can see, a 4.3 by 16 millimeter implant is going to take me right up to where those plates diverge. On the posterior sites 4 and 13, I'm able to place implants directly into the CBCT. and use realistic sizes and plan ahead for my transsinus implants so that I know that I'm going to be using 18 millimeter implants for my transsinus positions. And then in the anterior, I'm able to place 11.5 and 13 millimeter implants. So looking a little bit more deeply into the CBCT, I'm able to really place the pterygoid implant into the tuberosity bone, and then I'm able to angle it and kind of see in cross section where my anatomy is. So in this case, I'm using a 16 millimeter implant, and you can appreciate how dense the bone gets as I get to the apex of the implant. It's much wider and brighter, and that's a good sign. That means that as I put my implants into position, I'm going to have an increasing insertion torque. This is kind of what the transsinus implant is going to look like. You can see it's just barely glancing the anterior wall of the sinus. So I'm not going to have to do anything to the sinus membrane in a case like this. Here's our more traditional straight implants in the anterior maxilla. And here's the other one on the other side, site 9 or site 10. Here's a good view of the transsinus implant on the left patient's left side, site 13. And you can see I'm going from stable bone on the alveolar ridge, at least 4 to 5 millimeters of it. Then I'm going through some air in the sinus, and then I'm anchoring on the opposite end of the sinus with my 18 or no, this actually was planned as a 20 millimeter implant. This is the contralateral pterygoid. So again, looking for the pterygoid, the tuberosity volume, and then using that kind of like a funnel to go up to the pterygoid plates and engage the dense pterygoid bone. You can kind of see on the medial aspect of this scan, you can see kind of where the greater palatine artery is and how it courses up along the sinus wall past the apex of our implant. Another case that we did a few years ago for Michelle, she was already in a denture, so this was her denture, and she desperately wanted to get rid of this. This was actually a remade denture, so this was the improved version. But you can see high smile line, not a lot of bone. So this is a good opportunity to use pterygoid implants to compensate for our lack of vertical height. So as I mentioned at the beginning of this presentation, it's nice to have implants that are 13 and 16 millimeters high. In this case, we were only able to get maybe 10s and 11 and a halfs in the anterior maxilla. And so pterygoid implants really helped in a case like this because I was able to drastically increase my AP spread and support for this resorbed maxilla. So this is just going through some of the scans again and choosing the right implant sites. Again, most of the time, pterygoid implants are 13, 16, or 18 millimeters long. These anterior implants are shorter, so you can see instead of my normal 16 millimeter implant for this site, I'm forced to put an 11.5, which is much shorter. So increasing the number of implants and the remote anchorage for the support is really going to help a case like this. In the anterior, you can see I'm kind of doing kind of a semi-palatal approach here. There's not a lot of bone on the palatal side. So instead of reducing this bone even further and maybe only being able to put eights in, by using palatal approach, I'm able to put a 10 millimeter or even 11 and a half in this site. This is the other site in the central, site 9. So you can see it's a 4.0 by 10, kind of mid-ridge, but a little bit of a palatal approach there. And then here, I'm forced to put an 11.5 as my posterior stop here. So then going over to the other side and using the pterygoid bone. And you can see how dense and how wonderful this cortical bone is. But you can also see how close I am to the greater palatine artery right there. So we're talking millimeters away from vital structures. So this is why I do not recommend people do these cases without thorough training, hands-on and didactic, and having done many arches without these before you ever start doing these advanced procedures. So yeah, so this is kind of the take-home message, which is the majority of full arch cases can be done with straight implants, tilted implants, pterygoid implants, palatal implants, and transsinus. So you can see that zygomatics are left off this list. I'm not a big advocate of zygomatics in general. I'm definitely not a big an advocate at all for quad zygomatic cases. I think that we can do 99.9% of the cases with straight tilted pterygoid palatal and transinus implants. And so lastly, I'm just going to kind of go through what we teach at the surgery courses for full arch masters. I like people to understand the complexity of cases. And so level one cases are cases where the surgeon can place 4 to 6, usually 6 straight implants, straight up and down, using straight multi-unit abutments. They don't have to worry about angling implants around crucial structures. They can place from first molar to first molar, usually 6 dental implants on the maxilla or the mandible using straight MUAs, and you get really good support in all zones of the maxilla and mandible. So if you don't understand, if you don't remember the zones, the zone one in the maxilla is kind of canine to canine. Zone two in the maxilla is the distal half of the canine to the mesial of the molar, and zone three is from first molar back. On the mandible, kind of the anterior zone is between the mental foramina, and then the posterior body of the mandible is from the mental back. So if we can have support in all 3 zones of the maxilla and both zones of the mandible, that's what we should shoot for. And usually this requires at least 4 to 6 implants and usually either straight or tilted approaches. So the next level up is what I just mentioned is what our tilted implants help us with. And these cases are a little bit more complex because you have to tilt implants around away from vital structures like sinus, like nasal floor, like nerves and blood vessels. But you can accomplish tremendous things with this approach because in areas in maxilla and mandible where there's not as much room, you can tilt implants and have almost the same amount of AP spread on your case as putting 6 implants in straight, but you can do that with only 4 implants tilted. So these do tend to be longer implants because we're tilting away, and so we have more room to run the apex of our implant into solid bone. And you can achieve tremendously stable results using this technique. Kind of a next level up from doing straight and tilted implants is to combine straight and tilted implants with pterygoid implants. So this is kind of the next evolution of full arch cases. And we covered why we use pterygoid implants because we want to load cases, we want to have posterior support, and we want to decrease, increase our AP spread and decrease the forces on our cantilevers. So this is kind of the next level up, and kind of just as complex and just kind of as tricky are our palatal approach implants. Very doable for most cases that have resorbed ridges. I've done palatal approach cases where just the posterior ones are palatal approach, or just the anterior ones are palatal, and I've done cases where all of them are palatal, and they all work out great. Like I've said, I've done many cases that would have traditionally needed zygomatic implants as palatal approach cases, and patients do just as well, if not better, when they have a severely resorbed maxilla that's restored with palatal approach implants compared to zygomatics. The next level up in terms of complexity is our transinus implants. And I mentioned that these are very tricky implants because you have 2 insertion points to worry about. You've got your first insertion point at the alveolar ridge, then you've got your secondary insertion point on the lateral wall of the sinus. And so it can be very disorienting and very difficult to find the path of insertion for the entire length of your implant. But if you do, and you can get your implant to engage those 4 cortical plates, you will have outstanding insertion torque, and you can use those implants right away. This, as I mentioned, can greatly increase your AP spread. As you can see here, if I was completely in front of the sinus, I would have very close implants on the right side. But now I have really nicely spread out implants for this case. And kind of the most invasive and most complex dental implants that we offer are our zygos. And these cases are usually reserved for the most resorption, and they usually involve remote anchorage for almost all of the implants. So you usually end up with a pterygoid, a zygomatic, and tilted implants, or a vomer implant, or something, very advanced and skilled for most of these cases. Most of the time, if I can avoid a zygomatic implant, I do. But some patients, that's really the only bone they have left. So we still provide them with zygomatic implants, but as I mentioned before, it's becoming less and less and less in my practice. So there's a couple of things that they wanted me to include. I guess that they have a nice bundle for you guys, which is our CBCT with the 3D facial scanning. Has a lot of amazing capabilities. We talked about facial scanning a lot in previous webinars. I use it every single day, and I use my CBCT so much that it's usually smoking by the end of the day. Don't forget to get your CE credit for this presentation. If you have any questions, you can always reach out to me. You can go on fullarchmasters.com. You can email me at drdunlop@fullarchmasters.com. If you have any questions for the guys at Ray America, you can reach out to them here. You can send an email over to them as well. So that's about it. If I don't know if there were any questions, we can kind of go through them.
None since the last time you asked, Doctor.
Okay,
So
good.
we'll reserve. Yeah, I guess everybody's just like, yeah, we'll ask later. But everyone, thank you so much for joining us once again. CBCT planning for advanced full arch implant cases with Ryan Dunlop, Better Life Dentistry, and also Full Arch Masters. Doctor, thank you once again for doing this. I'll see
Yep.
you at Greater New York if luck allows it. And anyone else who's visiting Greater New York, please feel free to visit us at our booth, 3813. Ask us some questions about either the Vision series, the Quantum, or even our new 5D software that we are softly releasing.
I can't wait to see it.
Yeah, right. All right. So, everyone, once again, thank you for joining us. Dr. Dunlop, a pleasure always. Love the content and looking forward to more of it in the next coming year.
That sounds great. Thank you guys.
Wonderful. Have a great evening, everyone. Have a
Yeah,
good
bye.
night. Take care.